I'm joined by Steve Schroeder, the chairman of the commission, and Rich Kravitz, who's a member of the commission, as well as Mark Schwartz, who chairs SGIM's Health Policy Committee. You'll hear first from Steve, who will give a brief overview of the commission and its recommendations, and then from Mark, who will talk about how SGIM is beginning to operationalize the recommendations. We'll then open it up for questions. Today's webinar will end at 5 o'clock Eastern Time, which is about. Before we begin, just a few housekeeping requests. First is please mute your phone. If you don't know where your mute button is, press *6, or mute your phone. Second thing, if you'd like to ask a question, and we'll get to that after the presentations, please use the online chat feature. You'll see the chat box on the bottom right-hand side of your screen. Please type your question in that box and click send. And those of us here who are organizing this will see the questions come in and we'll feed them back to the group depending on how many questions we get. We have a team on hand to troubleshoot any technical difficulties you may be experiencing with the sound or slides, which you're about to see. And if you have a problem, please send a chat message to us about that, and we'll do our best to address your problems. Just write a note in the chat box, the same box where you can ask questions. No promises, but we'll do our best to get it right. Now I'll turn it over to Steve. Steve Schroeder, you're there, and look forward to hearing from you.
Andy, thanks, and I must say it was a pleasure working with you and your fine team. So Rich Kravitz is on the phone too, and he's going to be the brains behind the scene and will chime in. I'm going to just spend a few minutes summarizing our recommendations. I think many of you on the phone may have read them, so I won't go into them in great detail. The major purpose of this phone conversation is to get your questions and comments. So let's go to the next slide. And the next slide states what, unless Rip Van Winkle's on the phone now, everybody understands that the United States is facing a healthcare problem, that we're spending much more than other countries. Quality of care is uneven, access is substandard, and our health, as we measure it in various ways, isn't up to where it should be. So next slide. The rationale behind, if I have the next slide, please. The rationale behind establishing this group was our president, Harry Selker, the SGIM president, who presided over a membership group of about 3,500 members, was very concerned about rising costs of health care, the opportunity costs that flowed from those, the fact that we weren't getting great value, and having been in the field for a long time, understood that the decisions that a doctor makes are really critical. Now, some people say, well, gee, expenditures by a doctor, paying the doctor, whether it's fee-for-service or salary, only comes to about maybe 20% of the whole healthcare pie. Why should that worry us? But as you can see from this, there's an extra 60% that's influenced by the kinds of a decision that a doctor might make, such as should someone be hospitalized, should they get an imaging procedure, should they get surgery. So it was that rationale that spurred the establishment of the National Commission on Physician Payment Reform. And on the next slide, you will see that put together a commission that had...
It was the coolest thing.
If someone
my God.
Those who are not speaking, anyone who's not ought to have phone on mute now. Thank you.
I'll take one out
See
here.
that we've got a membership that includes MDs. It's mainly internists, but not fully. The people whose names are in orange are members of SGIM.
It was last week.
The intent of proposing this group was that we have peers, administrators, business leaders, various consumers, and so that we have the credibility so that this won't seem like a set of recommendations that was very predictable, but a set that reflected the common wisdom of this group. As you can see, former Senator Frist was the honorary chair, and I had the honor of serving as chair. So I should say that when the Institute of Medicine does does an effort like this, they typically have from 4 to 6 face-to-face meetings. Our budget didn't permit that. We only had one face-to-face meeting. It was scheduled to be in October. Unfortunately, Superstorm Sandy canceled that, so we had our meeting in early December, and not all of the members were able to come, although some called in by phone. But we had a lot of back and forth on telephones and various forms of talking things through, so that everybody had a chance to weigh in on the recommendations, which I'm going to show you, and also the draft of the report, which you've seen. So, next slide, please. Oh, and I should mention, of course, that on the previous slide, our two sponsors were the Robert Johnson Foundation and the California Healthcare Foundation. So, the 12 recommendations, I'm going to split them into several slides. The first slide focuses on fee-for-service. And what we said there was that people have been trying to fix fee-for-service, and it's biased valuations which reinforce doing more volume and reinforce doing more high-tech services, trying to fix these for probably 30 or 40 years, and the fix just doesn't seem to stick. And we basically said, we don't think it is really fixable. Let's migrate from fee-for-service. Let's phase it out. We ought to phase it out over about a 5-year period as we evolve, as we test, as we make things better. But in the meantime, and this is where we might differ from some experts who said that fee-for-service is going to vanish. Don't let its problems worry you. We said that we do need to fix it in the short run, because if we don't fix it, and if it doesn't go away as fast as we're going to say, or if residues of it stay in operation, then we're going to continue to have those biased values. So, next slide shows that we were looking in how to fix it here, and said that for both Medicare and private insurers, the annual updates in what they pay should increase for the E&M services, which are common not only to primary care specialties like general medicine, but also to other specialties that don't have an intensive use of medical technologies. And so we got to freeze those, but we should increase annually the E&M services, both in the public and the private sector. For the last several years, there's been a major discrepancy in payment for the same service, depending on whether a hospital owns it, in which it's much higher, or whether it's done in a physician's office. And we couldn't find any justification for that, for a procedure done outside of a hospital setting. And so we said that difference doesn't make any sense, and they all ought to be paid at the same rate. And then finally, we said that as we move into as more and more fee-for-service contracts take place, even though we're going to be phasing them out, that we should incorporate quality measures. The next recommendation, which is on the slide here, recognizes that much of the country doesn't have the density of doctors and doctors' groups to be able to form groups that can contract. So we said in these small and isolated practices, we ought to be able to form virtual relationships, and that fee-for-service payment should reimburse these small practices for care not delivered in person, such as by telephone or email, and also if various clinical services are shared, such as nutritionists, social workers, or mental health providers. Next slide, please. Here we're talking now about bundled payment, or fixed payments, and we felt that we should follow Sutton's Law here and move into areas where there's a significant opportunity to save costs, such as care for people with chronic medical conditions or in-hospital procedures and their follow-up, and that to protect against underuse, we should have safeguard, and also for cherry picking, getting rid of patients who are more vulnerable, and kind of trying to encourage the sign-up of people whose expenditures are thought to be less, that we should adjust those fixed payments for risk, and also should assure a strong commitment of doctors to their patients. Slide, please. So the last three recommendations are related to Medicare. And you all know about the SGR. And we were one of a very large number of voices that says the SGR just doesn't make any sense, that it's unsustainable, and so it's a farce. So let's close it down. The CBO felt that there are $138 billion that would need to be recouped either from the healthcare system or elsewhere, and we felt there's a sufficient amount of waste and overuse in the healthcare system that many of the changes being proposed, including the ones in our report, could recoup that $138 billion, and we shouldn't take them just out of doctors' salaries. We should take them out of savings to the Medicare system as a whole. And then finally, we had a lot of time on the Relative Value Scale Update Committee. Everyone on the committee, on our commission, recognized that there have been flaws in the RUC. We applauded that they've added some new seats in primary care and geriatrics, and the requirement that the vote totals for all the recommendations be published. We encourage that the RUC looks to further streamline and update its reform process. And we also encourage CMS to seek alternate sources of information so they wouldn't be as dependent on the RUC as they have been in the past. Next. So what happens if nothing happens? If we continue to pay doctors in the same old way with inflationary pro-technology biases under the fee-for-service system? Well, it's pretty easy to predict that our healthcare costs are going to keep going up. When I first started working on costs and how doctors get paid in the 70s, everyone was very upset that if things didn't stop, we'd be up to 10% of GDP. Well, we blew by 10%, and we're going to hit the 20% level pretty soon. And everybody, I think, is now recognizing the opportunity costs. And I think we're probably at a stage where people are more serious about the need to rein in costs than has been in certainly my lifetime as a doctor. Also worry that if we don't rein in those costs, quality of care will worsen, access to health care will worsen, there'll be more bankruptcies, the healthcare system is going to struggle. So there's some urgency in acting now. On the next slide, shows you two versions of this that are in print. On the right is our report, and you can download the full report and also the sounding board NEJM article that Senator Frist and I co-wrote on www.physicianpaymentcommission.org. For those of you who are coming to the SGIM annual meeting in Denver next week, I should say that there will be a session Thursday afternoon. I believe, Rich, it's at 3:30. Is that correct?
I think that's right, yes.
Okay, and I don't know the room number, but you can find that out. Rich, we're a little ahead of schedule, so I'm going to ask you to chime in on any things that you think ought to be augmented as after my summary.
Steve, I think you made all of the major points. I would only add that another impetus, I think, for the convening of this commission was Harry Selker's insight that we've kind of been down through this road of health reform before. The way it happened was a little bit different than it's happening now, but in the 1990s with various forms of tightly managed care coming in and then going out, and a number of the ethical quandaries that raised for generalists as gatekeepers, that this was actually an opportunity for a society like SGIM to get ahead of the game, and that's one reason that the commission came to be.
Okay, Mark, I think you're up next.
Great, thank you, Steve. The Society of General Internal Medicine has since endorsed the commission report. Its council voted to support the commission's recommendations, and Ann Madinger, our president, has established a task force to operationalize our support and advocacy for the commission's recommendations. Steve mentioned that the commission was sponsored by the two foundations, and these foundations their grantees are constrained from advocating directly for legislation, and therefore SGIM will carry the torch for this agenda. And while we will continue to look to the Commission for ongoing wisdom and advice, SGIM will take it from here. The task force will work closely with CRD Associates, which is SGIM's government relations professionals, to first map the recommendations onto the congressional committees of jurisdiction in both the House and in the Senate. And in addition, we're working to develop more granular language that will help policymakers translate these recommendations ultimately into legislative language. We look forward to working in an ongoing way with the professional staff of the Finance Committee in the Senate, and on the House side, the Energy and Commerce and Ways and Means Committees. In this collaboration, SGIM will aim to promote the social strategies and to develop the political will to move physician payment policy in the direction that was envisioned by the Commission's report. We are seeking partners of two types to carry this work forward. Of note, the Commission distinguished, you'll note as you read the language, between cognitively focused evaluation and management services and procedurally focused services, which is a broader approach than emphasizing primary care versus subspecialty distinction. And it's our hope that we can gather a broad coalition of other organizational partners to advocate for strategies to promote more cognitively focused E&M, or evaluation and management services for our patients. And I'll just finish up by saying that we're also very welcoming of SGIM members to join in this work. We seek partners with advice out in various regions of the country. And the best way to do that is by contacting me at the email address on the slide that you see. You can also learn more about the work of the Health Policy Committee by looking at the advocacy page of SGIM. So let me stop there and see what questions we have.
So thanks, Mark. Thanks, Steve. Thanks, Rich. And we're going to open it up to questions. As a reminder, if you'd like to ask a question, please use the online chat feature. You'll see it right there on your screen. It's at the bottom right-hand side of your screen. Please type your question in that box and click send. And also, please state your affiliation so we know where you're coming from and can tell everybody else. Obviously, or presumably, you're affiliated with SGIM, but within your own organization. Let me start with a question or two and then give you all time to ask your questions. So I throw this out to, I guess, any of the three of you to start, which is, given the multiple conversations going on around this topic in the policy world, where do you think the Commission has broken new ground or moved the ball in this conversation, and why do you feel that way?
Steve, do you want to take that?
I'll start, but I'd be interested in what everybody else has to say, too. I would single out the fact that we worked with both public and private payers. Many of the conversations have only been dealing with other groups, have only been dealing with the CMS. Secondly, I would say the fact that we said we made a pretty bold statement saying let's phase out a fee-for-service, but we also said let's fix it. And I think the third thing I would say is that may have stood out is the site-specific payment differentials, which I've not heard other commissions like there, other groups like this take on. But I'd be interested in what Rich and Mark have to say.
I would certainly echo the site-specific issue. It raises some eyebrows because it's a more novel idea and a potentially resolvable one.
Yeah, I think Steve's second point is really important. One of the principal findings of the Commission was that the country really can and should be able to walk and chew gum at the same time, and that even as we move pretty decisively towards phasing out fee-for-service, or at least down-ramping it over a period of 5 years, that we also try to fix the system we've got, because some aspects of fee-for-service are going to be with us for a long time, and there are aspects of the system now that are that are both truly pernicious and actually readily fixable. So I think the fact that the Commission took on both issues at the same time, I think, is quite important.
Okay, I'm going to go to some questions. We have a few. Deneen Grooms has a question. Have you received any feedback on your report from MedPAC or CMS, for example?
We went around, Andy, Dr. Kavita Patel, a member of SGM and one of the members of our commission, did the rounds on Capitol Hill, both parties, both houses of Congress. The feedback that we got, nobody quarreled with the what. They all felt this was an interesting and a supportable set of recommendations. Several predicted there'd be pushback on the site-specific from hospitals, and some staffers wanted to know more of the how, the kinds of things that apparently Mark is going to be working on with the SGIM group. So, for example, what kind of quality adjusters would you use? What kind of adjusters would you use? To get to Dr. Groom's the specifics, we have not yet heard back from MedPAC or CMS, although we did consult with a couple of senior MedPAC people in getting the background for the report, and there's not. We line up fairly closely with MedPAC, although MedPAC doesn't talk about private payers.
Thanks, Steve. Another question, Barbara Turner's question, who do you believe your key partners will be? Turn to Steve and Rich on this, and also Mark, given your SGIM advocacy role.
I'll start, but I think Mark's probably closer to it than I am. I mean, one of the things that we debated as we were running up to writing the report is, should this be a primary care focused or should this be broader? And I think it was pretty clear, almost everyone, I think everyone, Rich, said, no, let's focus on not just primary care, but on the services that all doctors do and try to level the playing field to make a rational system so the incentive is to do the right thing, not in the balance to do the better paying thing. And so in so doing, in taking what I think is the right stand, I think we have the capability of bringing on a lot of the non-tech internal medicine subspecialists, plus many of the pediatricians, the psychiatrists, the neurologists, even some people in GYN. So that would be my answer, but I'd be interested in Rich and Mark, who are a little closer to the ground on this issue.
Yeah, no, I'll just say one sentence. I think this is one of those rare occasions where the politics and the policy kind of converged, and the right policy was certainly to focus on E&M and care coordination, because that's not specialty specific. But it also turns out to be the right politics because it doesn't seem as self-serving.
I agree with that. I would point to the participation of Steve Weinberger on the commission, Executive VP of the ACP, and specifically we're hoping to have an ongoing collaboration with ACP in this effort, which of course addresses the desires and needs of generalists and specialists. I'll say one more thing
Mark,
about
we
that.
also had a cardiologist and a cardiac surgeon on the commission.
Correct. Right. Yeah, I think from the policymakers' perspectives, they don't want to hear from 20 different subspecialties on who gets paid what. They need a cohesive message, and I think it was wise to broaden it to a broader scope. From SGIM's perspective, it raises a bit of a challenge in that we have typically advocated for primary care services per se, so we'll need to adapt a bit to ensure that we're consistent with the broader message.
I want to add a comment because I've been with Steve on some of these meetings on Capitol Hill, and there was a question from Jeff Jager who had asked, what's up with efforts with larger organizations, and all of you addressed some of that. I do want to say we're not done yet. We've met with basically the most relevant and important people on Capitol Hill at the staff level. We met with one congresswoman, and representatives of some organizations. We are now hoping to make contact with the most senior people at some of the insurance companies, the payers, to gauge their interest in the report and to see how they might move forward with some of the recommendations. And our plan is to do this over the next couple of months. So between Capitol Hill and some of the interest groups and some of the healthcare-related provider organizations that may or may not be, that are more provider-focused than being interest groups on the outside of the provider scene, as well as the payers, I think we're covering most of the waterfront. And we've gotten a very favorable reaction so far. Not as much as Steve said on the how, and no one has walked away with us giving a sense of how to write a piece of legislation, but they're certainly getting principles that are being laid out, and they seem to be embracing them. I also want to add that the reaction has been quite bipartisan, that we've met with Republican and Democratic congressional staff, and as far as I can tell in terms of tone, I don't feel much of a difference. So,
yeah, I would add to that, Andy. I think I think both parties are very concerned about costs. Where they differ is where the cost savings come from, like from the SGR, the $138 billion in that. And that one party is more likely to want to cut benefits than the other. But we chose not to speak to that issue in our commission report.
We have another question from Priya Radhakrishnan saying from St. Joseph's Hospital in Phoenix, within the context of health reform and PPACA, what are the chances that the recommendations will be endorsed by the broader medical community and the other competing lobbies? And Mark, why don't you take a crack at that, since nobody knows the answer, but you might be closest to it.
Well, of course, we're all participating in various ways in alternative payment models now that have been launched by the Affordable Care Act and its Center of Medicare and Medicaid Innovations. And it's certainly our hope that these will be rigorously evaluated, and those that are successful, because they're pilots, the Secretary will be able to scale up. The degree to which they're going to be endorsed is a tougher question. Depends who you mean by the broader medical community. I think the advantage is that there's close agreement on what the problems are. And there's increasing agreement on what some of the solutions are. But I would underline Steve's point that exactly how we get there and how we pay for it will be where politics enters in, and where stakeholders will have to battle for their interests.
Priya had a follow-up question which is related, but it's succinct. It's a really good question. In the world of ACOs and MSOs, how do we create a broader platform to push the message of fee for quality, where there's a relationship between cost and quality?
Yeah, that's a great question. I'm going to take it one step further. One of the unknowables right now is when a bundled payment goes to an ACO, then how does the ACO decide to pay its constituent physicians? And there are a number of different ways of doing it. One is with relative value units, and I think the concern is that this will just be fee-for-service in sheep's clothing. One will be to figure in value. One will be to figure in patient satisfaction. One will be to figure in efficiency. And I think this is such a decentralized process that it's going to require a lot of people out there working locally and at the state level, because it's the ACOs that really set up those rules. It's interesting that in the more kind of established ACOs, like the Kaisers, there is some cross-subsidy, so that those physicians earn more marketplace of fee-for-service, maybe make a little less, and those who earn less in the marketplace maybe earn a little more. The differential between specialists is still great, but it's not as great. And I know at places like Kaiser, they do factor in those ways. There is no kind of agreed upon one tool to measure quality. So I think we're still in the thousand flowers bloom area. Rich, as an editor, you're sort of at the cutting edge of this. What forecasts do you see?
I'm not sure that my experience as an editor prepares me to say, but I do see a couple of challenges to the implementation of our commission's recommendations, aside from the politics, which of course are in themselves daunting. One is that the models like accountable care organizations and even patient-centered medical homes have barely begun to be tested. And we don't have a lot of time. We're not going to have 10 years to figure out, in the context of a Rand health insurance experiment, what works and what doesn't. So we're going to have to identify proxy outcomes and rapid cycle evaluations that can give us some preliminary answers sooner rather than later. But the other actually does have to do with the sort of the immaturity of the methods for measuring quality and for risk adjustment, and even figuring out how to tell what patients are assigned to what ACO. So I think Priya has raised a really important question. I don't think we have a complete answer to it, but we're going to have to go to war with the army we have, and the army we have are a set of quality measures that actually have developed, have come quite a ways over the last decade or two, and we're going to have to start with what we have and then rapidly improve from there.
And Priya, the only thing I would add, this is Steve once again, is that individual leadership at the ACO level is going to be a major factor here, because the decisions about what ACOs do and how they count and how they score and how they pay are going to really vary from place to place. So this is an opportunity for our members and other healthcare professionals to get involved in the governance activities at that level. Mark, anything you want to add on this?
Yeah, sure. Priya, I have a broader policy response, which is that the last three recommendations of the Commission focused on Medicare with a particular focus on the SGR. And to Rich's point of walking and chewing gum at the same time, I do think that we need to do what we can to address some of the flaws in the current payment system, while at the same time we try to undo the SGR and replace it with something better. There's you mentioned it briefly, Steve. The cost of such a repeal, currently estimated $138 billion, which is an awful lot of money. But just a year or two ago, it was approaching $300 billion. And so there's a great deal of energy and interest in striking the bargain while the price is relatively lower, in terms of how much would be required to pay for it. And SGIM, along with many other stakeholders, are working closely with both the Energy and Commerce and Ways and Means committees in the House, Republicans and Democrats, Republicans in particular, who have been floating a framework for such a sort of a multi-phased process of stable payments for several years, and followed up with quality measures which would drive payment in subsequent years.
Please visit our website.
Okay, so time for a provocative question. Alan Garol from Harvard has this question, a question of prioritization. Is not the report's specificity, let me get this question here, isn't the report's specificity on fixing fee-for-service and vagueness on how to get to risk-adjusted comprehensive payment, as was first proposed in 2007 by SGIM, doesn't that actually risk slowing the payment transformation process?
We will see, Alan. It's a fair question. We laid out a 5-year time plan. I don't have your 2007 recommendations in front of me now, but we called for fee-for-service to be phased out, and I believe the headline on the NEJM article was phasing out fee-for-service. So pretty explicit on that and saying that it ought to go. But the worry I had is in talking with a lot of the people who are bundling advocates and writing about that, they've basically been saying, don't bother fixing it because it's going to vanish. And fee-for-service is like Rasputin. It took a lot to put him down, and I think fee-for-service is hardier, and there are more things keeping it going than we've given credit for. So I think the risk of saying don't do anything to it, don't try to fix it, is outweighs in the view of our commission the risk of saying, oh, it's just going to go, let's not bother. But others might come out at a different point in that. That's where we came out. We did talk that issue through. Rich, you were there.
Yeah, I guess one other salient issue maybe is that even if the larger healthcare organization is paid in some capitated or bundled way, it's possible that individual physicians will still be paid fee for service, and that that payment system at the sharp end, even if it's taking place under the main policy radar, can still have a distorting influence on career choices and other kinds of things that we're interested in. So the commission felt that even as we try to nudge the country towards a more comprehensive fix and phasing out of fee-for-service, that the fee-for-service system really had to be reformed, because it probably will never go entirely away, even if the way in which it's retained is just as a payment mechanism within healthcare organizations rather than across them.
Thanks to both of you. Karen Weber has a question from Exempla St. Joseph Hospital in Denver, a short commute to the annual meeting. Her question is, how will payment reform affect access to care for uninsured patients?
I think a lot of this is going to depend on the state. States obviously are going to vary in the extent to which they accept the Medicaid expansion of the ACA, and so far a lot of them aren't going to. The other thing that's going to happen is under the ACA, states are going to, many of them are going to really try to cut costs by paying doctors for even less than they've been doing. So independent of whether we're bundled or fixed or in a fee-for-service system, states are going to, by how much they budget into particularly how they pay people under Medicaid and what kind of provisions they have for uninsured, are going to make a major difference. The safety net is still going to be critical. The federal qualified health centers. The fact that the county hospitals are going to get their dish payments cut back under the ACA, and yet many providers, especially specialists in many states, won't accept Medicaid, is going to mean that the challenge, it's just having the ACA go through, unfortunately, isn't going to solve all the access problems. I'm not yet worried about Medicare so much as Medicaid and uninsured, but we may come to that too. So I think this is going to be an issue that's going to stay with us. And it's going to stay with us, I think, in both forms, in both bundled and in, many bundled groups won't accept Medicaid.
Yes, I think, Steve, with respect to payment reform, though, the one thing the commission did consider was just how there would have to be mechanisms for assuring that accountable care organizations and like entities don't shun the very sick or those who are socioeconomically disadvantaged. So there will have to be incentives built into any payment system that's developed in order to avoid worsening access to care. Of course, it's true that under the current fee-for-service Medicaid system, for example, it's not like access is great. So you can have good access or poor access under either system.
Let me ask you a political question. See where we are with this. There were 11 or so recommendations from the commission, and commissions, of course, throw out a bunch of ideas and hope that some actually land. If going forward, what's your prediction or sense of which of these recommendations will get the most traction first, and which there'll be the greatest urgency in terms of response?
And you don't want to try to answer that, Andy?
You guys, I'm going to say no. I asked the question.
Fair enough.
Mark, I would trust your answers first.
Me too.
Well, I've given you a partial sense of it that the SGR question is alive. Of course, as every year we kick the can down the road, and the rates are frozen through this calendar year. So something will have to be done by the end of the year, as Congress has done every year. But I think there's a real unique opportunity for a solution that around the pay-for is because the cost of it is so much lower. I think we may see action outside of Congress on the administration side within CMS regarding payment codes to try to address some of the inconsistencies and the undervaluing of cognitive services. There may be strategies that CMS can implement under their current authorization. So I think those are two areas that might move earlier.
Yeah, I would say that there's bipartisan support right now for getting rid of the SGR, but where the $138 billion is going to come from is quite partisan now. So I don't know whether you can solve the one without solving the other. So that is certainly a chance. I think the E&M issue has a chance of making it both in the private payers and under CMS, and then site specific. I heard stories that some members of Congress are now in their speeches to doctors and hospital groups saying that they're going to try to make action on that. And I think there is a general sense that we should move out of fee-for-service. But boy, I find it tough to predict what's going to happen in Washington these days. Rich, do you have a good crystal ball?
I think if I did, it's been shattered recently. So no, I don't have any predictions.
Okay, we have a question from Matthew Mercuri, who's an NYU medical student. Is physician payment reform sufficient for lowering healthcare costs in the long term if we don't also address the overpricing of medical resources, services, etc.?
That's a great question because, in that initial pie graph that Steve showed, physician salaries only and expenses only account for 21% of the healthcare dollar, and there's a lot of other costs folded into the total picture, including things as diverse as long-term care and durable medical equipment and so on. And there's been quite a lot of attention paid by health economists lately about how, I think there's a article in Health Affairs from some years ago called "It's the Price is Stupid," which basically points out that a big part of the cost differential between the U.S. and other countries is in the prices we charge for healthcare services. So it's not. You're right, the questioner is quite correct that it's not just physician fees. On the other hand, physicians do control the use of a lot of other healthcare services. So at least in terms of utilization and volume, the physician payment system can have large downstream effects, I believe.
If you look at the report starting on page 7, there's a section on why the United States spends so much on health care. And the solutions to your excellent question are a little bit like the solutions to global climate change. It's naive to think that one single strategy will make all the difference, but it's useful to add as many strategies as possible. So sort of looking at, starting on page 7, fee-for-service reimbursement is 1, our reliance on technology and costly care is 2, a high proportion of specialists compared to primary care physicians is number 3, the consolidation in the healthcare industry with the pricing advantage care at the end of life and our extremely costly pattern as compared to other countries, high costs to manage our billing and other procedures, fear about malpractice suits and the high number of lawyers and suits that we have here, fraud and abuse, and also the high appetite. I've lived overseas, and our patients, I think, are more demanding. Our customers want more. They want it now. They want someone else to pay for it. If they don't get it, they're going to want to sue. So it's complicated here. But our commission thinks that how doctors are paid is part of the problem and has to be part of how we solve that problem.
And if I could respond to Matt as well, who's a student of mine here at NYU and just earned an A+ for a great question. As Tom Bodenheimer and Kevin Grumbach and others have written, there's sort of these phases of cost containment. We've gone through much of the painless options of promoting EHRs and prevention and primary care. That'll only get us so far in terms of cost containment. We're now into some of the painful stuff of structural reforms of delivery system changes and ACOs and patient-centered medical homes and bundles and all that. I suspect that that will be insufficient, and that we'll have to get into the more very painful cost containment in the decade to come, which will involve more explicit addressing of prices because they are highly variable and much higher in this country than in many other countries.
So Priya wins the award for the most questions, also good questions. Will physician payment reform affect transparency of prices in the healthcare system? And will this issue of opacity of price, in healthcare be addressed?
Well, if any of you saw the Time magazine article by Stephen Brill, the transparency issue he really shone a huge spotlight on that. That's a big issue, and people have been talking about that for a long time. There will be pressures on more transparency. How quickly that'll go into real transparency, I don't know, but I think you're really onto something because it is very hard to figure out charges and costs, and the two are obviously very, very dissimilar. Payment reform may help that, but it's not a magic bullet. That is a reform of how doctors get paid.
Yeah, it's very interesting. If you go to any large airport these days, you're likely to see an urgent care center somewhere in the airport with a big sign out that lists prices for office visits, simple lab tests, preventive screenings, immunizations, and the like. But you don't see that in the typical physician's office or hospital. The commission didn't, to my knowledge, didn't directly address this kind of transparency issue. We did talk a lot about transparency with respect to the RUC, and we hope that transparency in the way that physician fee schedules are developed will be part of the solution to the overall problem that we've addressed. But the kind of transparency you've raised is also something that we're going to need to look at in the future.
I want to give a shout out. Barbara Turner raised a good point earlier that I want to just get out on the table in terms of who we need to reach out to explain the recommendations and to engage in conversation. And what I didn't mention but should have is where we have an intentional plan to reach out to industry as well. We want to be meeting with the Business Roundtable and other business-oriented groups that represent an umbrella, that are the umbrella for a bunch of other groups within business, because obviously it's not just the insurers, it's those who have to, who do employ people who are affected by this. So outreach will include them too, and we'll see what the uptake is. But Barbara, thanks for raising that point. Another question is an open-ended one, but I think an important one. What do you see as the biggest challenges for implementing these recommendations? And I'm going to throw in an editorial comment other than the sort of ongoing budget battles on Capitol Hill and as Steve pointed out, sort of the differences in priorities between the two parties. assuming those could be dealt with in some grand bargain that I just made up, what do you see as the biggest challenges for actual implementation?
I'll weigh in with the fractured nature of the medical community. The fact that only about 20% of people belong now to an umbrella group, that is the AMA, means that every physician's loyalty is essentially channeled through his or her specialty society. And a great bulk of the activities of those societies, and we heard this when we went around the Hill, is to try to protect their turf, and that's the way lobbying works. And if it's a zero-sum game, then doing less for a technology and more for E&M means that those specialties represented by the technologies, many of which have a lot of clout on Capitol Hill and with private payers, aren't going to want to do that. And so that's going to be a major sell. Mark, it'll be interesting as you work with ACP and others to see what kind of compromises can be crafted for that.
I agree. I think it's a challenge. As I mentioned before, from SGIM's perspective, we have to figure out how to thread the needle in that we've been accustomed to advocating for general internal medicine, primary care values and our mission as a society. And this is a society effort that I've been asked to undertake, but recognizing the risk of being specialty or even service line specific in the advocacy for the reasons that you mentioned. I had the chance to sit on the other side of the table for a year with the Ways and Means Committee a couple of years ago, and I know that the staffers and the members see group after group, specialist after specialist come in, and while the AMA certainly, as you said, is fewer than 1 in 5 physicians, they are the largest group, and it's really tough to gauge the political wins from the staff's perspective when you've got this multiples of specialties coming and claiming that they're underpaid, and it's going to hurt the patients. So I think it's wise for us to keep a broader approach as we advocate for these principles.
There are a number of things, of issues that people brought up in our discussions that we didn't work on, and one of which I think is very, very critical, and I'm hoping someone listening will be spurred into action. That is rising medical school tuition and the huge debt burden that medical students face when they go into practice as physicians. I think exerts a huge toll in this country that it doesn't overseas, and yet that issue seems off the table, probably because there's no easy way to fix it.
Okay, this will be the last question. It's from Bob Brown. Can you comment on the likelihood of site-neutral payment for services rendered in the hospital outpatient department setting being included among the payment reform elements implemented? Let me ask it again. Can you comment on the likelihood of site-neutral payment for services rendered in the hospital outpatient department setting being included among the payment reform elements implemented for both E&M services as well as for procedures and for cardiac imaging and other sorts of procedures?
It's a good question, and I don't have a fair prediction on it, except that there's considerable interest in this as an idea. Over the last handful of years, the reimbursement rates for certain imaging procedures, particularly radiologic and cardiac imaging procedures done in the community, the rates were cut fairly dramatically, and we've seen an exodus of many of these proceduralists into the hospital OPDs and hospitals to do them there because reimbursement rates were so much higher. I think we can anticipate a significant amount of pushback from those proceduralists who continue to benefit from the higher payment rates in the hospital.
I'm a little more optimistic just because this change has been so obvious and is so recent. And so I think it's easier to correct something that's recent. What's happened basically, it's been a windfall. Hospitals are now getting increased revenue for things they didn't used to do. and the specialists who get bought out by the hospitals are being guaranteed income that they didn't used to get. So I think all of them recognize that this is a short-term windfall and that they may not get it in perpetuity. That said, it's much easier to give than to take away.
For sure.
Okay, I think we are all set, and I think we've actually answered all questions that have been asked, which is good. Thanks again to Steve, Rich, and Mark for doing this. Thanks to SGIM for putting this on. And just a reminder that on April the 25th, which is Thursday, the conversation and the presentation of the report will be at 3:30 in the afternoon at the Governor's Square room, Governor's Square 17 in the hotel. Governor's Square 17 at 3:30 in the afternoon on Thursday. And, of course, it'll be in your book when you get there, but a little heads up as to where to go. And you should also know that the recording of the webinar will be available on the SGIM website within a few days. So you and or people you want to refer to will have access to it. And with that, I want to wish you all a great afternoon, and thanks very much for listening and participating. Bye.